My name is Craig Smith. I'm a second year PhD student at the University of Glasgow. I'm a member of the TRACK programme, and my project is on the development and validation of a risk prediction tool for head and neck cancer. So some quick definitions. I think I might be preaching to the choir with this slide, but of course head and neck cancer constitutes squamous cell carcinomas of the oral cavity, the pharynx and the larynx. It's the 8th most common cancer globally, with some 878,000 incident cases in 2020 alone. And this incidence has risen by a third over the last decade. One of the major drivers underlying this is human papillomavirus, or HPV, which is attributable to 50% of oropharyngeal cases alone. So we have a twin challenge. We've got growing incidence and already stretched healthcare systems, so clear need for primary prevention methods, but also patients typically presenting and ultimately being diagnosed at advanced stages, which has a clear impact on patient prognosis and outcomes. So if I refer to the stream of care here, what we really need to do is try and catch patients more upstream, or even prevent them from falling in the river per se in the first place. In light of this, risk tools have been proposed as a method to improve early detection and promote behavioural change. However, few head and neck cancer risk tools have been developed, and even fewer have been tested clinically, and to our knowledge, no one has reviewed these. And at this point, I should emphasise not all risk models are tools, but all risk tools usually derive from models. In light of this, we conducted a literature review of any existing head and neck cancer risk models. We performed a search of Medline and Embase and imported the results into Covidence, where the results were dual screened at a title and abstract at a full text level, according to a strict inclusion and exclusion criteria. The credibility and applicability of each model was examined using the PROBAST instrument, which is a peer-reviewed quality appraisal instrument specifically designed for risk models, so it fits our research question perfectly. We also conducted an independent overall quality assessment, attaching a decision to each model based on 3 primary considerations, these being the PROBAST risk of bias, PROBAST applicability that I mentioned in the previous slide, and also a model's validation methods. Increasingly now, external validation is widely considered to be the gold standard in clinical risk model development, ensuring that it is both reproducible and generalizable to the population. And at this point, I should emphasize, high quality is not necessarily equal to high performing, which is why we assess performance separately. We assess various performance metrics, but the main one I'm going to present to you today is discrimination, also known as the area under the curve, or the C-index. So a quick statistics crash course. Discrimination is essentially the ability of a diagnostic test or tool to discern between those that have an outcome and those that do not. In this case, is an individual at risk of head and neck cancer, or are they not? On the left-hand side here, we have an ROC plot. The black line here represents an area under the curve of 0.5, which is essentially the value of no difference. At this point, you may as well flip a coin as to whether your model will work. The red line represents approximately a value of 0.6, at which point a model is considered to be the minimum clinically acceptable in terms of discrimination. Then finally, we have the blue line, which is approximately 0.8, at which point a model is considered to have good or excellent discrimination. So, what did our review identify? The results of our screening process are summarised on the right-hand side here with our PRISMA flowchart diagram, but we identified 14 papers as a result of our search and inclusion criteria. And I won't labour on these too much, but it was a very heterogeneous mix with papers identified from across the globe. The majority of these use a case control design or built upon previous case controls for model development, and most of these used a form of logistic regression analysis approach in order to calculate individual risk. In terms of quality, of the 14 models, 6 were deemed to be high quality. The factors affecting this being that PROBAST risk of bias, that PROBAST applicability, and validation methods, as I mentioned in previous slides. In terms of performance, 8 of the 14 were deemed to be high performing, and in terms of a balance of both, of the 6 high quality models, 3 also exhibited good performance. And these are the big 3, as I sometimes refer to them. So the first model of interest we have is Amar Singh and colleagues. This is a Sri Lankan model designed to assess the risk of or potentially malignant disease in the population. And what this model did in particular to set itself apart, arguably, is the inclusion of betel quid. So for those that are unfamiliar, betel quid is a form of chewable tobacco commonly seen in Southeast Asia, and it is a major risk factor for or potentially malignant disease and or cancer in this population. And this resulted in the model performing very well. Moving swiftly on to the next model, we have Tika and colleagues. This is a ENT model developed in the ENT department in Glasgow. And what this model did, arguably, to set itself apart was its inclusion of clinical signs and symptoms we would associate with head and neck cancer. So, for example, lymphadenopathy, unexplained weight loss, dysphagia, persistent intraoral red or white, or mixed lesions, so on, so forth. And this resulted in the model having a good performance of 0.89. Interestingly, this is also the only model of the 14 that we could find any sort of real clinical use associated with this model, and it was used to triage patients in secondary care during the pandemic. And finally, we have Tota and colleagues, which was an American oropharyngeal cancer risk model, and this was actually developed using data from the SEER registry. And what this model did in particular to set it apart, arguably, was its inclusion of HPV serostatus. Now, if we recall back to my opening slides where I said HPV is one of the major risk factors for oropharyngeal cancer, it's then perhaps unsurprising to see that the model performs very well with a discrimination of 0.87. So what are the key findings bringing all this together? All the high quality models incorporated the major head and neck cancer risk factors of tobacco smoking and alcohol consumption. It's well established these have a synergistic effect. The higher quality models, in particular those high performing high quality models, generally all required clinician input, i.e. a patient couldn't fill this in themselves. High quality, high performing models I mentioned too, that big three, they were more specified models carefully tailored to their target population or subsite, as I illustrated to you in those examples. And perhaps counterintuitively, models that included many additional risk factors actually had a lower predictive performance. You might think the more risk factors I include, the better my model will be. And that's not actually the case. And there is a statistical reason for this, and this is what we call overfitting. And essentially this means that you tailor a model too closely to a developmental data set, so then when you go to test it in an external independent data set, its performance ultimately suffers. As Shakespeare may have put it, sometimes less is more. The review is also similar in nature to systematic reviews of other risk prediction models for other cancer sites, including colorectal, breast and melanoma risk models. And in terms of performance, the head and neck cancer risk models were largely on par with these, and in some cases actually performed slightly better. So in conclusion, there's a limited but growing number of head and neck cancer risk prediction models, some of which do have that potential to identify and stratify those at risk. However, further work needs to be undertaken to refine and validate these models. Moving on to phase 2 of my own project, we're conducting model development using the ARCADE study. Now, this is a multi-centre European case control with 15 centres across 11 countries. And at the time of writing, we have 1,926 head and neck cancer cases following the exclusion of esophageal cancer cases and 2,043 controls. The descriptives of the cases are summarised here by subsite on the right-hand side. I won't labour these too much, but what I will draw your attention to is early probing regressions have produced error under the curve values as high as 0.78. which is quite promising. We're currently undertaking 3 different strategies to test for our final variable selection. These first of all being a black box approach, which essentially entails running every variable we have to check we've not missed any key players. Our second approach involves an a priori selection, looking at previous ARCADE studies, essentially what does the literature say are the big players, but also looking at what we have available in biobank, so slight spoilers for the next slide. And finally, our third approach includes an a priori selection with a focus on what is practical clinically. So, what are our next steps? We would look, once we've completed model development, to externally validate in the UK Biobank. We now have the data for this. It's a large UK-based cohort study with over 500,000 participants from across the UK. So crucially, it's not just a large and robust, but hopefully also generalisable cohort that we can apply our model to. We'd also look to pilot our model clinically, and perhaps introduce a lab component to support this. However, the exact details of this are to be confirmed with the track programme at this time. So some quick acknowledgements and thank yous. A huge thank you to my supervisory team, Professor Conway, Professor Inman, Dr. McMahon and Dr. Ross. A big thank you to my colleagues in the Community Oral Health Department and the Oral Medicine Department in the Dental Hospital. And a big thank you to my colleagues in the Queen Elizabeth University Hospital ENT Department, as well as Paul Cannon, who's our subject librarian, who helped us develop this review strategy. I'd also like to give a big thank you to the TRACK programme and Cancer Research UK. Without their support and funding, this research would not have been possible. And last of all, I'd like to thank you all for your diligent time and attention. I'm more than happy to take any questions. I've attached my email and a link to my Twitter here if you wish to contact me this way. I hope you enjoy the rest of the conference as much as I have. And thank you very much, ladies and gentlemen. I hope you enjoy the rest of your day.
Hello everyone, my name is Alex. I'm the statistician for Head and Neck 5000, and this presentation we're looking at the treatment of older people with head and neck cancer. Some background to justify why we think this is important. So older people represent a significant proportion of people with head and neck cancer. In the UK, 35% of people diagnosed with head and neck cancer are 70 or over. Because of the higher incidence rate for older people and the aging population globally, this means that in the future it's likely that not only will there be more older people with head and neck cancer, but they'll represent a larger proportion of all cases. Treatment in older people can be challenging for different reasons, including comorbidities, frailty and side effects, and as a result, older people are less likely to receive standard treatment. However, not all old people are the same, so whilst some older people have frailties or comorbidities, many others will remain healthy and active well into later life. So if we focus too much just on chronological age, then there's a risk that many older people won't be receiving the best treatment. In this presentation, first we're going to look at the characteristics for younger and older people with head and neck cancer. Then we'll look at the differences in treatment between the groups. And then finally, we did a survival analysis to try and see if any of the difference in survival between younger and older people was due to differences in treatment between the groups. So for this analysis, we defined older people as older than 70. Obviously, it's not that straightforward to define older people, and that's sort of the point of the analysis, is that nothing happens. There's no switch that gets flipped when you hit 70, but obviously for this analysis, we had to draw a line somewhere, and based on other studies, 70 was quite standard for defining older people. So Head and Neck 5000 recruited more than 5,000 people in the UK, and in this analysis, we're focusing on people with squamous cell carcinoma who received curative treatment. So this gives us 4,498 people, of which 974 were aged 70 and over. Data capture forms were completed by research staff to collect information on tumor site, treatment type, TNM stage, and comorbidity, and we defined HPV status using HPV 16E6, and if serology was missing, then we used P16 data. Some results comparing older and younger people. Proportions of men and women is the same in the two groups, and then tumor site, we see greater proportion of oral cavity, larynx in older people, and a higher proportion of oropharynx in younger people. And then if we focus on oropharynx, if we look at HPV status among oropharynx, then 71% of cases for younger people were HPV positive, compared to 59% for older people. And TNM stage, so for younger people, 64% of cases were late-stage disease, and 45% for older people. And as expected, older people were more likely to have comorbidities. Only a quarter of older people didn't have any comorbidities, compared to half of younger people. And then here we're comparing the treatments between younger people and older people. This includes everyone, so overall, younger people are more likely to receive chemoradiotherapy only, and older people are more likely to receive surgery only or radiotherapy only. So the next slide, we're going to look at these results by tumor site, and we've also stratified by stage. This are results for oral cavity. So we've got the same treatment groups as before, excluding the last two because of the small numbers, but otherwise it's the same groups. So the graphs show the percentages of younger people on the left and older people on the right, the percentage of people receiving each type of treatment, and the top graph is for early stage disease, and the bottom graph is late stage disease. So it's fairly similar. The main difference here is that for late stage disease, younger people are more likely to receive chemoradiotherapy either alone or with surgery. And then for HPV negative oropharyngeal cancer, here the main difference is for late stage. Again, here younger people are twice as likely to receive chemoradiotherapy than older people. And then for HPV positive oropharyngeal cancer, here we've used ICON S. If I was doing my slides again, I probably would have included another slide on ICON S staging in TNM, because we've talked a lot about staging, but the main difference here was that using TNM7, most of the HPV positive OPC cases were classified as late stage, but with ICON S, most of them were classified as early stage. And so here the main difference, again, younger people more likely to receive chemoradiotherapy. And finally, for larynx, again, the main difference is in younger people more likely to receive chemoradiotherapy. This slide here, we're stratifying by comorbidity instead of stage. So it's clear that the main difference between younger and older people was chemotherapy. Here, these graphs just show the percentage of younger and older people receiving chemotherapy. So did their treatment involve chemotherapy? And so stratified by comorbidities, we've got none, mild, and moderate severe. If we just look at no comorbidities, then for each tumor site, we see that, again, younger people are much more likely to receive chemotherapy than older people, or older people are much less likely to get chemotherapy. So then we did a logistic regression to compare chemotherapy between older and younger people. So we adjusted for sex, tumor site, comorbidity, TNM stage, and HPV status, and the odds ratio was 0.22. comparing chemotherapy between the groups. And then finally, we did have a look at a survival analysis. So we looked at two models, one partially adjusted for sex and tumor site, and a fully adjusted model also adjusting for comorbidity, disease stage treatment, and smoking. And so if we just look at the overall results, we see that adjusting for treatment and other confounders didn't really make a difference. And also we did look at the models adjusting for confounders individually, and adjusting for treatment didn't really make a difference. In conclusion, there's clear differences in treatment between older and younger people, and these don't seem to be explained by comorbidity or disease stage. Treatment should be based on biological age, otherwise older people may not receive the best treatment, and more studies should evaluate treatment and outcomes in older people. Okay, I want to thank the following people, and thank you to the organisers of this conference, and thank you for listening.